Friends, I'll be sharing some of my thoughts on the management of perioperative hypertensive crisis and oliguria. Hypertensive disorders are the most common medical complications of pregnancy, especially in our country, with an incidence of about 5 to 10%. It is a major cause of maternal and perinatal morbidity as well as mortality. The Joint National Commission on the Prevention, Evaluation and Management of High Blood Pressure has categorized blood pressure into 4 types: normal, pre-hypertension, stage 1 and stage 2 hypertension. A patient is labeled as hypertensive if his systolic blood pressure is more than 140 and diastolic is more than 90 millimeters of mercury on 2 occasions in a patient who is already labeled as hypertension. Although not mentioned in JNC Report 7, hypertensive emergency or hypertensive crisis is a condition in which the systolic blood pressure rises to more than 180 millimeters of mercury or a diastolic pressure of 120 millimeters of mercury with or without an organ damage. It is further subdivided into a hypertensive urgency or an emergency based upon the level of the blood pressure which has risen, as well as the presence or absence of an end organ damage. A postoperative hypertension is a systolic blood pressure equal to or more than 190 and a diastolic blood pressure equal to or more than 100 millimeters of mercury on 2 consecutive occasions. Now, what is the importance of differentiating between a hypertensive urgency and emergency? Because it helps us to formulate a therapeutic plan. In a hypertensive emergency, you will have some time to control the blood pressure using oral medications, and you can take about 24 to 48 hours to control the blood pressure. However, in a hypertensive emergency, the blood control has to be done as soon as possible with the use of parenteral medications. This is because this condition is associated with increased incidence of end organ damage like acute MI, hypertensive encephalopathy, intracerebral hemorrhage, dissecting aneurysm, renal failure, and pulmonary edema. What is the most common cause of a hypertensive crisis? It usually occurs in a patient of chronic hypertension who has skipped his medication. The secondary causes which can lead to a hypertensive crisis include renal diseases, preeclampsia, and certain endocrine diseases. The National High Blood Pressure Education Program Working Group on High Blood Pressure in Pregnancy in 2000 categorized hypertension of pregnancy into 4 categories: chronic hypertension, gestational hypertension, preeclampsia, and preeclampsia superimposed on chronic hypertension. The American College of Obstetricians and Gynecologists divides preeclampsia into 2 types, mild and severe, and describes hypertensive emergency as a SPP more than 160, DBP more than 109, or MBP more than 126 millimeters of mercury. The precise pathophysiology of a hypertensive crisis is not known. However, it is speculated based on the pressure and humoral hypothesis that there is a critical imbalance of pressure and or humoral factors to produce this condition. Actually, multiple parameters may be involved. The condition may be multifactorial, involving the renin-angiotensin system, or because of endothelial damage, which increases the permeability, results into the accumulation of coagulation factors and fibrin, producing tissue ischemia, vasoconstriction, and end organ damage. Whenever a patient of hypertensive crisis presents to you, you should find out about the onset, the duration, and severity of hypertension which the patient has, whether there is any prior organ damage, the associated symptoms. You should also look out for a list of medication patient is on, the dosing, the compliance with the antihypertensive regimen, and the time and dose of the most recent ingested treatment. The clinical manifestations of hypertensive crisis depend upon the organ involvement which the patient has, whether it is a cardiac involvement or a renal involvement or it is, in case of severe preeclampsia, it can be a HELLP syndrome or eclampsia. Now, based upon which organ is involved, the patient may present with chest pain, back pain, dyspnea, altered consciousness, seizures, oliguria, right upper quadrant pain or epigastric pain, and nausea and vomiting. In the physical examination, you should measure the blood pressure in bilateral upper limbs with an appropriate sized BP cuff. And if possible, you should try to measure the blood pressure in the sitting, standing, and the supine position so that you have a rough idea what is the volume of the patient. The pulses should be palpated in both upper and lower extremities. You should hear for the bruise for the presence of carotid and abdominal arteries. The fundus examination should be done for the presence of hemorrhages, exudates, and papilledema. And neurologically, the patient should be assessed for the conscious status, the presence of coma, or any focal neurological signs. An elevated JVP, third heart sound, gallop, or pulmonary rales are in evidence of cardiac failure. Preeclampsia is categorized as severe based upon the blood pressure reading, which may be, as I mentioned earlier, more than 160 millimeters of mercury. There may be proteinuria, and there may be signs and symptoms pertaining to the cerebral, to the liver, and to the kidney or pulmonary edema to label it as severe preeclampsia. Similarly, HELLP syndrome can be diagnosed by the presence of an abnormal hemolysis leading to a rise in bilirubin, raised LDH levels, elevated enzymes, and a low platelet count. When you investigate a patient, you should have a complete blood count with a focus on the platelets. The peripheral blood smear should be examined. The urine should be analyzed for the presence of casts, blood, or proteins. In the metabolic panel, you should concentrate on the electrolytes. Liver function tests and renal function tests also need to be done. ECG is important. And imaging studies may be important in situations where the patient shows focal neurological deficits, the patient has a prolonged coma, or the seizures are not responding or the blood pressure is not responding to your medications. The management goals consist of an immediate admission to an ICU. And you need to control the blood pressure with a parenteral titratable antihypertensive agent with continuous monitoring of invasive blood pressure, seeing also for the neurological status as well as the urine output. The sublingual and the intramuscular routes of management should be avoided. In severe preeclampsia, the management goal should not be the normalization of the blood pressure, but reduction of blood pressure so that you do not compromise the end organ dysfunction as well as you don't compromise the uteroplacental circulation. The guidelines say that you should correct the blood pressure to no less than 20 to 25% in the first hour. And if patient stabilizes, then keep the blood pressure up within 160 by 100 within the next 2 to 6 hours. The recommendations are to keep the BP from 140 to 160, diastolic of 90 to 105, and mean of 105 to 125 millimeters of mercury. In preeclampsia, it is said that you should start treatment at lower doses of the antihypertensive agents after you have made some improvement on intravascular volume status, because you don't want the blood pressure to fall suddenly and cause fetal hypoxia or any end organ damage. Now, what should be the timing of delivery? This is decided by the obstetrician, who will look at the risk factors both for the fetus as well as for the mother. If possible, the pregnancy should be allowed to continue up to 34 weeks of pregnancy. However, if the patient does not respond to your antihypertensive medications, she shows signs of impending eclampsia or any deterioration, then the pregnancy should be terminated as early as possible. So the first step in the initial therapy should be the optimization of your fluid status. Magnesium sulfate should be given for seizure prophylaxis. The patient should be monitored for blood pressure, pulse, respiration, deep tendon reflexes, and mental status. The intake and output should be maintained. The fetal heart should be monitored after the fetal evaluation has been done based on the non-stress test, ultrasound for fetal weight, amniotic fluid volume, and Doppler measurements. Now, what is the role of invasive monitoring in this crisis? The invasive monitoring is a very important aspect of the management of hypertensive crisis because rapid changes in hemodynamics takes place. This is due to the fact that the disease is progressing and the preeclampsia is also associated with volume depletion. Invasive monitoring is also very important for assessing the oliguria and also to monitor what is the patient's response to fluid administration. The relative merits of pulmonary PA catheter over CVP are debatable, and there are no outcome studies to show that PA catheter has advantage over CVP. You should also keep in mind the possible role of non-invasive cardiac output monitoring, where you need only an arterial cannula to calculate the cardiac output, calculate the systemic vascular resistance, and guide the management of your fluids, the antihypertensives, and other drugs. Now, whether you should fluid load or you should fluid restrict? There are no definitive studies on the optimal type and the volume of the fluid which is required. If you look at the advantages of plasma volume expansion, you feel that you will correct a relative decreased intravascular volume of preeclampsia. You will also avoid a precipitous fall in blood pressure because of either starting an antihypertensive agent or giving anesthetic agents. And you will also maintain the placental and renal perfusion. However, there are certain disadvantages in fluid loading. These patients have high chances of pulmonary edema because their colloid oncotic pressure is less and the hydrostatic pressure is more. And in certain situations, there may be severe left ventricular diastolic function which can precipitate pulmonary edema. Various types of antihypertensive agents are available for management of hypertensive crisis, which are all categorized here. However, most of the antihypertensive agents which we use in pregnancy are designated as category C. ACE inhibitors and angiotensin receptor blockers have teratogenic effects and they should be avoided. The reason for hypertensive crisis in pregnancy is increase in peripheral vascular resistance. So ideally you should use drugs which decrease those. The first line drugs in the management of hypertensive crisis in pregnancy are hydralazine and labetalol, and the second line drugs are nitroglycerin or nicardipine and sodium nitroprusside. In the initial period, hydralazine was considered to be a good drug to use for reducing the blood pressure in pregnancy because of the fact that it did not cross, there were studies to show that it did not cross the placental barrier. However, if you think about it, it's not a very good drug for this purpose because of the fact that the onset of action is slow, the duration is long, and some of its side effects are difficult to differentiate with the development of eclampsia. Labetalol is a good drug because it has both alpha and beta properties. It does not cross the placental barrier and it maintains the coronary, cerebral, and renal perfusion. In a normal pregnancy, there is an increase in renal blood flow and GFR, which leads to a fall in the values of creatinine, urea, and uric acid. Oliguria in preeclampsia can be due to vasospasm and capillary endothelial swelling. It is defined as oliguria if the urine output is less than 0.5 ml per kg per hour or less than 400 ml in 24 hours. The oliguria in preeclampsia may present in two forms. One is with low filling pressures, elevated SVR, and hyperdynamic cardiac function, which signifies hypovolemia, or it can show a normal or elevated filling pressures, elevated cardiac output, and high SVR. In these patients, in preeclamptic patients, it is very difficult to predict how the patient will respond to fluid loading. This is because there is a poor correlation between the CVP and pulmonary capillary wedge pressures. The American College of Obstetricians and Gynecologists recommends PCWP monitoring if oliguria is present in that patient. In a patient with oliguria, if you have evidence of hypovolemia, you can try a fluid challenge of about 200 to 250 ml of crystalloid, see the response. Ideally, you should aim for a CVP of 4 millimeters of mercury or less, because if you keep the CVP at 6 to 8 millimeters of mercury, it will correlate with a PCWP of 18 millimeters of mercury, which may be very high and lead to pulmonary edema. What is the role of loop diuretics? Loop diuretics basically convert an oliguric phase of acute tubular necrosis to polyuric phase, and it may be particularly useful in oliguria with pulmonary edema. However, there may be a problem of volume depletion which may aggravate the acute renal failure. The loop diuretics as well as mannitol, low-dose dopamine, ANP analogs, calcium channel blockers, their role has not been proven in pregnant population because the number of studies done in this population with these drugs is limited. If hyperkalemia is present, then potassium-free fluid should be used. The mild hyperkalemia should be managed with loop diuretics, and severe hyperkalemia needs urgent treatment with GI regime. In case of ECG changes, you may need calcium gluconate. If the patient shows features of uremia, there is metabolic acidosis, and there is hyperkalemia, probably patient requires dialysis. Now, what about the anesthetic management? In the pre-anesthetic assessment, one should focus on the airway examination because the chances of difficult airway are more in this population. You should also look at the hemodynamic parameters, how much is the blood pressure, and what you need to do to bring it down. You should also keep an eye on the fluid balance. Patient should be administered aspiration prophylaxis irrespective of the type of anesthesia you want to use. As mentioned by Dr. Sunanda, it is recommended that the oxytocin in low doses should be slowly administered to the patient. The neuraxial block is not contraindicated in preeclampsia. Rather, it maintains the blood pressure and the outcome is good, provided your platelet count is normal. The advantage of neuraxial block are that it provides maternal blood pressure which is stable. It optimizes the uteroplacental perfusion. One thing I need to add to this is that when you are providing a neuraxial block, there is no role of fluid preloading. What you can do is probably give a spinal block, give a combination of fluids and vasopressors in case your blood pressure drops. The CSE is a good technique of anesthesia which can be used both for labor analgesia as well as for surgery. The problems of anesthetic management if you give general anesthesia is the possibility of a difficult airway. You may have a severe hypertensive response to intubation and extubation, and you need to use drugs to blunt that response. The magnesium sulfate which the patient is getting may interfere with neuromuscular transmission and uterine tone, and the hypertensive shoot during pregnancy, like it happens during intubation, carries the risk of cerebral hemorrhage and pulmonary edema. General anesthesia will be indicated in patients who have coagulopathy, they have fetal distress, pulmonary edema and cerebral edema. Post-operatively, these patients have to be monitored in an ICU for 12 to 24 hours, where magnesium infusion will be continued. Fluid balance will need to be maintained, and if the patient is still showing signs of renal failure, maybe she will require dialysis. Post-operatively also, you need to keep stable hemodynamics, you need to watch for the urine output, you need to watch for eclampsia, you need to watch for all the things which can happen in the intraoperative period. I conclude by saying that anesthetist has a crucial role to play in the management of pre-eclampsia patients. The initial stabilization of this patient requires careful fluid therapy. The ideal antihypertensive agent which may be required to bring down the blood pressure remains to be established. Regional anesthesia is safe both for labor analgesia as well as anesthesia. Thank you.